We have some time for some questions. Gordon? And you can also ask questions to...
Okay. What happens to ethics in medical practice when we have QOF? Because you'll find that doctors will be doing things because they'll get paid for it rather than maybe the patient needs it. And then what does that then do to patient-centered medicine as opposed to doctor-centered medicine? Because then the doctor's telling the patient what to do instead of discussing it with the patient.
Yeah, I think that's an important point, and in a sense the key issue is whether the incentives are for things that doctors believe they should be doing with patients anyway. So if you take an example, few people would dispute that people with high cholesterol and ischemic heart disease should be offered a statin. Whether the patient wishes to have that prescription is entirely up to them. What the incentive does is it makes sure that the doctor discusses that with the patient, and if the patient says, I don't want a statin, then they exception report that patient. I think one of the things we have seen in the UK is that the first bundle of indicators that were brought in were very much in line with established professional practice. They were things that most doctors felt they should be doing anyway, and probably felt a bit guilty that they weren't doing. Since then, indicators have been introduced which are much less clearly in line with established practice and seek to change practice. And they have been much more controversial, and I think the issues that you raise are potentially more problematical.
Marika Mäkelä from Finland and Denmark. Thank you for a really interesting presentation. And when I think of what Frede was talking about, chronic care, preventive care, acute care, and diagnosing the things that we don't know, when we look at the salary systems, they mostly concentrate on chronic care and preventive care. So do you think there's an effect on how we do one of the most important things that we do as doctors, which is to diagnose new diseases and to take care of acute things?
Yeah, I don't know the answer to that question. So they are all on chronic care. There are no indicators on acute care, and you'll be well aware that the whole business of how you measure the quality of acute care is much, much more difficult. And indeed, one of the things which I showed you, I tried to compare incentivized and unincentivized conditions, but they were all chronic conditions. So I didn't even touch on what has happened to acute care. And so I don't know the answer to that question. One of the things I do know is that we have expanded the range of professionals who see people with acute problems. So people in the UK are much more likely to see a nurse or a nurse practitioner if they come in with a minor illness. And frankly, I don't think we know what the impact of that has been on acute care or on diagnosis.
Yes. Yes, Theo Verheij from the Netherlands. I really enjoyed your talk as well. Thank you for that. I have a question about study 2. You showed us a graph comparing diseases without indicators and with indicators, showing that the disease without indicators didn't improve or hardly improved. But are they comparable? Because I saw the lines were before you introduced the system. The lines were already. The slope of the lines was already markedly different.
Yeah.
So that's made me suspicious about whether they were comparable.
Yeah, I think that's a good point. Unfortunately, the slide I showed you had one pair of lines. The full slide has 3 pairs of lines, which makes it even less interpretable. It is extremely difficult to identify truly comparable conditions. We started off in this study trying to have 4 cells, so the incentivized aspects of care for incentivized conditions, and then completely different diseases and different aspects of care were measured. And then also to have 2 cells which would have, for example, a blood pressure measured, but in a disease that wasn't in the QOF.
All right.
And that made it even more impossible to interpret. I mean, one of the things you're pointing out is that the incentivized conditions were already improving more because they were the more important ones. They were heart disease and diabetes that, all our countries have been having quality improvement initiatives in. So it makes that sort of comparison extremely difficult. all I think I can say in my defense is that my conclusion is roughly in line with other studies that have been done, that it probably doesn't make the other conditions get worse, at least.
Okay, thanks.
Thank you. Joachim Szczeni?
Joachim Szczeni from Germany. Thanks for your talk. On one slide you showed when you withdraw the incentive, then the quality of care is going down. But as I interpret it, it even goes more down than the level it was before. But what would that mean? Does it mean you really have to raise the incentive, or once you have started you always have to give incentives? Because otherwise you might have the problem that the level of care is even lower than it was before.
Yeah. While you're passing the microphone to Helen Lester, who might answer the question since it's her study. Tina, can you give the mic to Helen so she can answer the question? I'll let her give the first answer, and then I'll give a second answer.
No, that's not fair. I'm Helen Lester. Yes, right. Don't know. As the honest answer, because you're right, it did with diabetic retinopathy, it dipped lower. Martin showed 2 of the slides. There are actually 4 slides, and it's only in diabetic retinopathy that it drops below. It would have been nice to do some qualitative work, but it was old data. It was quantitative data only from Kaiser, so I would need to go and ask the doctors that were responsible for those to answer you truthfully. I can just say, certainly in one of the 4 conditions that we looked at, it did dip below, and I don't have a credible explanation for that. But Martin may.
Well, no, but let me introduce another possibility, is that nothing that I've talked about was due to the financial incentives. Because there are 2 things going on here. Remember that all the data are published and publicly available. So it's not just financial incentives, these are reputational incentives too. And doctors in England mind. They mind a lot. And they indulge in completely uneconomic behavior to try and get the last few points. And if you look, for example, at advertisements in the British Medical Journal for practices who are looking for a new doctor, they always say how many quaff points they get. This is a matter of pride for doctors. They don't like being thought as less good than the next person. So the direct answer to Joachim's question is that if you stop paying, but maybe continue measuring and continue publishing the data, maybe that would be sufficient, and maybe we didn't need to pay at all.
I'm Kees Veld from the Netherlands. Martin, thank you very much for your excellent lecture, and Frede also. We must not forget him, I think. I'm afraid this is a question for Helen Lester also, because it's from her figures. I was struck by the fact that when the cervical smears, you incentive them and not incentive them and incentive them again, but you don't reach the original level. So that could mean that you lose potential improvement by giving all this incentive business. What would be your reaction to that?
Just wait a minute.
Thank you. I only had that much data, as in we went back from 1998 to 2007, and in fact the reason it stopped there is that was all the data we had at that time point, so it might continue to go further up. The other thing that is important to point out, in the States they pay much less money against those incentives, so that it's not absolutely directly comparable. It's the closest, as Martin said, it's the closest data that we could find that helped us begin to explore this whole area. But they paid something like 3%, as opposed to, as Martin said, 20 to 25% in the UK. And the money actually went in at the level of the HMO, not at the individual GP. So the 3% that the HMOs got could only be spent by that HMO on, for example, new staff or new equipment. It was not money into your back pocket. So they're sort of helpful because it says something goes on when you take money away. But we didn't in the paper, for example, make any huge firm conclusions about what this means for paper performance. We could only say, as Martin put in his bullet point, look, there's something going on extra. I don't think you should take more than that as a message away.
Except you should please do some experiments.
I'm Ström from Sweden. Excuse me for my bad English, but payment for performance assumes that your main drive in life is money. It's not professional ambition. And there's a lot of other motivational factors to do a good work than money. And there's some, we have seen the same figures as in Kaiser Permanente, but when you reduce, you take away your payment, you fall below the former goals. And there's also some psychologic research by Bravo, Ryan, and Desi that your intrinsic motivation is deteriorated by payment for performance and such things. Don't you have any worry about that when you see these figures from Kaiser Permanente?
Yeah, absolutely. I mean, I think the Gagne and Decky work suggests that there is a threat to internal motivation. So what drives us as good doctors is largely our internal motivation. Everybody goes to work, well, most people go to work in the morning trying to do a good job. And what the psychological literature suggests is that external incentives of any sort can have the potential to damage internal motivation. Now, if you believe that internal motivation is the main thing that keeps medical practice good, then there is clearly a risk that external incentives will be damaged. And so that was the point that I was making, is that it is absolutely critical that external incentives are aligned with the internal motivation of the doctor, which in a sense comes back to your point about the ethics of it. So the incentive should encourage doctors to do the things which they believe they should be doing. As soon as you get external incentives clashing with the doctor's internal motivation, then you have real potential problems. And that's a situation you have to avoid and can best be avoided by people like us getting very closely involved in the development of such schemes if they're happening in our countries.